Inflammatory bowel disease affects millions globally, often resisting current therapies. We're constantly searching for breakthrough mechanisms, not just symptomatic relief. What if a key protective element of your innate immune system, a crucial peptide, is actually being hijacked, turning from a protector into a pro-inflammatory agent? This isn't just theory. It's a developing insight that could redefine IBD treatment. At the core of this challenge is cathelicidin, or LL37. Normally, it's a frontline defense, antimicrobial, immune modulating, and vital for gut barrier integrity. But recent research reveals a disturbing deviation. It's aberrant modification. Peptidyl Arginine Deiminase 4, or PAD4, an enzyme prominent in inflammation, citrulinates cathelicidin. This post-translational modification fundamentally alters the peptide's charge and structure, crippling its protective functions. It's not just impaired, it transforms into a pro-inflammatory mediator. This isn't just a loss of protection, it's an active driver of immune dysregulation. We're talking about a vicious cycle. Inflammation fuels PAD4 activity, creating more citrullinated cathelicidin, which then perpetuates gut barrier dysfunction and chronic inflammation. This shifts our understanding. It's not a lack of functional cathelicidin causing problems, but an abundance of its destructive citrullinated form. That's a critical distinction. This identification of citrullinated cathelicidin as a key pathological player flips the therapeutic script. Instead of just supplementing, we could enhance protective cathelicidin or, more directly, inhibit PAD4 activity. The promise here is immense. Interested in tracking this pipeline? Subscribe to the Clinical Cadence Digest at peptides.today for exclusive deep dives and regulatory forecasts. Now let's talk about the hard realities of drug development here. While the science is compelling, we are firmly in preclinical territory. There are no human clinical trial data for therapeutics specifically targeting this axis. Developing stable cathelicidin analogs that evade citrullination while maintaining full biological activity, suitable pharmacokinetics, and a clean safety profile is an arduous task. Alternatively, inhibiting PAD4 directly, a strategy explored in rheumatoid arthritis, looks promising in animal models of colitis. Data from DSS-induced colitis models show elevated cathelicidin citrullination mitigated by PAD4 deletion, suggesting clear therapeutic potential. But PAD4 also has physiological roles. The challenge is developing highly selective PAD4 inhibitors that target pathological citrullination without compromising essential immune functions. This is not a downstream cytokine block. This is an upstream fundamental restoration of mucosal homeostasis. This puts any potential therapeutic 10 to 15 years away, assuming an ideal, accelerated, and highly successful development pathway. The regulatory hurdles, especially demonstrating clinical relevance and safety for a novel target, will be significant. The cathelicidin PAD4 axis offers a mechanistically distinct and exciting new pathway for IBD intervention. While preclinical data are intriguing and PAD4 inhibition shows promise in animal models, the journey to an approved therapeutic is long and complex. Success hinges on highly selective compounds, a rigorous regulatory pathway, and compelling efficacy data against existing treatments. This represents a glimmer of hope for refractory IBD, moving beyond symptom management to fundamentally restore gut immune homeostasis. It's a complex puzzle, but with profound implications. Before we sign off, a quick legal disclaimer. This podcast is for informational purposes only and is not medical advice. All compounds discussed are for research use only and not for human consumption. Always consult a licensed healthcare provider for medical needs and treatment. Stay ahead of the clinical curve. The next great peptide is already in phase 2.